request Dr. Devi Aiswarya to present her.
Good morning, everybody. So I'll be talking on TENON'S patch graft with amniotic membrane graft and overlay technique. Yeah, so we know there are different modalities of managing corneal perforations and thinnings. Out of them, TENON'S patch graft is a known modality. The traditional method of doing this was an inlay graft, wherein an excess amount of TENON'S tissue was dissected and placed as an inlay graft in the area of thinning or perforation, and then it was secured by large cross sutures and then sometimes covered with amniotic membrane and a BCL. What we see is the pre-op and the post-op of such a technique. So you can see there's quite a large amount of vascularization, of course less than cyanoacrylate glue. There were reported cases of anatomical failure and clinical failure. How does it work? When we combine the goodness of TENON'S and amniotic membrane, TENON'S, as we know, is a fibrous, thick, rich in muscle tissue and muscle fibers and fibroblasts. It produces autologous fibroblasts in connective tissue, and it gives structural support, reduces inflammation. Amniotic membrane, as we know, is rich in growth factors. It has antibacterial, anti-inflammatory, anti-fibrotic, anti-angiogenic effect. So now coming to the video. Yeah, so we infiltrate that area where we are going to dissect. I usually choose the inferior fornix. Then we dissect out just an adequate amount of TENON'S, not any excess amount of TENON'S, just enough to cover the area of thinning. And we place it as an overlay, not as an inlay. How I came upon this technique was by accident. I had an accidental perforation on table when I was giving intracameral, and I had not taken a consent for therapeutic grafting. And so in the absence of anything, I just resorted to using the patient's own TENON'S, and I put it as an overlay because I could not place it as an inlay. So now, as you see, I'm simply securing that just adequate amount of TENON'S with 4 tenon nylon sutures, just adequate to cover that area. And on this, now that we have a dry base, we can just put a sufficient amount of amniotic membrane on it with the help of fibrin glue. In the absence of fibrin glue, we can use the patient's own blood, but since we have access to fibrin glue, I use that. And then I cover this area with just adequate amount of amniotic membrane so that post-operatively I can have a view of what's happening beneath it. And then once this is done, I just excise the excess amount of amniotic membrane outside of that graft area and then cover it with the BCL. And then follow up the patients as I would do any corneal ulcer patient. And then I put glue and I secure that area of conjunctival opening. So that's the end of the video. At the end, I put a BCL. So now these are some of my pre-op and post-op cases. As you can see, this is the first post-op day. In the traditional technique, because of the excess amount of TENON'S that we are using, excessive amount of post-operative swelling was causing loss of TENON'S adherence over there. And you can see how well the graft has taken up. It has integrated into the corneal tissue. Now this is another large desmetocele, more than 5 millimeter. Here you can see the post-op results after 2 weeks. This is one more. This is after 3 months post-op. This is one case which was almost lost. She was willing to give up the eye, an old lady. And in this case with the fistula, I had very little choice. I either had to subject her to a tectonic graft, which she was unwilling. So in the absence of everything, and since she was willing to give her eye up, I just put a TENON'S patch graft, and you can see how well she did after 3 months. So this is how well it has integrated. So now I had 18 cases with a minimum of 3 months post-op, and all of them had good anatomical success. 10 had more than 2 lines improvement, 6 underwent cataract surgery and had more than 4 lines improvement on the Snellen's chart. 2 remained less than 660, and they would subsequently need an OPK, but they were OPK ready. So in the absence of, so what I hope this helps us take a different look at the way we do therapeutic grafts and tectonic grafts. And it's absolutely low cost. It is more universal. It can be done on any patient. And it does not need a HOTA registration. Most of the corneal surgeons still remain without access to HOTA in our country. So I think it will help us save a lot more eyes. Thank you.
Aiswarya, yeah. So I have a lot of things to ask you. Good presentation. I think it was the rescue measure that you tried out and then you got caught on with it and then you took it further. I would first of all take severe objection to your saying that it is a low-cost measure. Anything that involves amniotic membrane usage in the surgery can never be low-cost, because
and as compared to a
I have not
graft.
yet finished asking what I want to ask. So procuring the membrane, to cleaning the membrane, to preserving the membrane, to using the membrane itself increases the inherent cost of the procedure. But my actual question was, the way I understood the first case which led on to your usage of this technique later, did have a perforation where there was an iris prolapse which was sealing the perforation temporarily. So what did you do about the iris prolapse if you had to just put TENON'S as an overlay?
Wherever the iris is at the wound already, ma'am, after I cover it with TENON'S, and
so
once
you
the
did
wound
not
is
attempt to de-epithelize or replace the iris prolapse.
No,
You
I
have
replace
just placed the TENON'S on top.
After the wound is secured, ma'am, then I replace it through a
Paracentesis.
side port.
Paracentesis.
Yeah.
So in that case, it wouldn't have been possible to de-epithelize the iris, right? So in an iris prolapse, when we do the TENON'S as a graft, normally you de-epithelize the iris, that immediately opens up the perforation, and then you put the TENON'S as an inlay and then cover it up with a bandage contact lens. Here you cannot clean up the iris because you are putting the TENON'S as an overlay. It is not an inlay. So the moment you don't clean up the iris and you put it back, you pave way for future epithelial downgrowth and problems like that. I wouldn't be in favor of doing that.
Can I speak, ma'am? In perforations where there is iris already at the wound, I remove all the debris on the iris. Then I remove de-epithelize the surrounding area till I get to the healthy area.
Okay.
Then I put enough TENON'S to cover that area of iris prolapse as well as a little bit of the healthy cornea, and then fill it up and then top it up with amniotic membrane. Once that is done, then I go in and I try to separate the iris.
Okay, even in that case, I would feel, it's my personal view, that usage of TENON'S patch and amniotic membrane together is an overkill. You could try this technique of overlay if you've cleaned up the iris and then you've put the membrane and then you have reposited the iris from a side port, is what you're trying to tell me. You could still do that and do away with the amniotic membrane and just try a bandage contact lens on top. If it works in this, it should work in that also. I understand and agree that you are providing, trophic factors, but with the use of the amniotic membrane. But then it considerably increases the complexity of the procedure as well as the cost. If you really want to try it, I think you should also have an alternative where you use only a bandage contact lens and see whether it works equally well.
Because I was using sutures to secure the graft and sometimes the peripheral, that is why I was covering up with amniotic membrane so that inside's less vascularization. That was my thought
A
process.
BCL will cover it equally well. And regarding your problem of graft loss, there is a simple tip that you can follow. When you're harvesting the TENON'S, you made a point that you take the exact amount. There is no need to take an exact amount. TENON'S is a free and easily available tissue. So long as you don't leave that opening exposed, you can take as much TENON'S as you want. So what I do is you take a little larger piece of graft, and then I put cautery marks in it. The cautery marks help to shrink the TENON'S. So once you do that, the ballooning up of the TENON'S because of aqueous outflow, the amount of vascularization that invites, much later after the procedure, these seem to come down once the spaces are shrunk in the TENON'S tissue. Small tip, you can take it if you want.
That's just what I was trying to emphasize, that in the absence of access to HOTA, and this is more doable for most of us. Like, the cost effectivity as compared to a corneal graft is less.
Definitely, but I wouldn't use both together unless I figure out one works alone as well.
Thank you.
Thank you.